Thank you all for joining us. Just want to take a quick moment to introduce our two speakers. We are very lucky to have two of the world-renowned experts in osteoporosis, bone health, and TBS for that matter. But first I'm going to introduce Dr. Lewiecki. He will be speaking second, but I want to have an opportunity to introduce to him so that when we make the transition, you will already know. If you already don't know Dr. Lewiecki, he's the director of the New Mexico Clinical Research and Osteoporosis Center and director of Bone Health Tele-echo at the University of New Mexico Health Sciences Center in Albuquerque. He supervises his center's osteoporosis programs and has a clinical practice for patients with osteoporosis and metabolic bone diseases. He has been an investigator for many osteoporosis clinical trials and has numerous publications in peer-reviewed journals, as well as abstracts, books, and book chapters. His research interests are focusing on developing new strategies to prevent fractures and reduce the osteoporosis treatment gap, which we all know is an issue. He is the vice president of the National Osteoporosis Foundation, which, by the way, it's National Osteoporosis Month in the month of May from the NOF. And he is also the president of the International Society for Clinical Densitometry. He's the founder and president of the Osteoporosis Foundation of New Mexico and program director for the annual Santa Fe Bone Symposium, which unfortunately is not going to happen this year, but we definitely look forward to it next year because it's a great program to participate in and everyone should attend. Our other speaker who will be starting the program is Professor Didier Hans. He's the head of research and development in the Bone and Joint Department at the Center of Bone Diseases at Lausanne University Hospital in Switzerland. He has extensive experience in DXA, bone macro and microarchitecture, ultrasound imaging techniques, as well as body composition assessment. Professor Hans teaches courses in bone and body composition imaging, as well as on osteoporosis all around the world. He served as International Society of Clinical Densitometry president and remains an active member of the ICD Board of Directors, as well as a member of the Scientific Advisory Committee of the International Osteoporosis Foundation. He has authored more than 300 articles, over 25 book chapters, and serves as a reviewer and or a member of the editorial board for more than 15 international scientific journals. Professor Hans was the recipient of many awards and recognitions, including the ISCD Research of the ISCD Research of the Year Award in 2019, for his global work on TBS, which is obviously opportunistic for us today to have him speaking on this. He also was the John Belazikian ISCD Global Leadership Award in 2013, as well as the ISCD Clinician of the Year Award in 2006 for distinguished services in the field of bone densitometry. So welcome both Dr. and Professors Michael Lewiecki and Professor Didier Hans. Didier, if you would like to go ahead and start, we will go ahead, I'll probably take my camera off so we can focus on what you're speaking about. And for all those who are participating, we have 110 now, that's great. We have a section, if you go through your Zoom, you will see a Q&A button. If you have questions as we're going along, please provide them. We will try to get to, we obviously won't be able to do all of them at the end of the session, but we will definitely try to do some of them. So please send them your way. If we can't get to all of them today, we will follow up with the answers at a later time. Okay? Thank you so much. Professor Hans, why don't you go ahead and get started?
All right. Thank you very much for that very kind introduction. It's almost a lecture. So the idea is for the next 20 minutes is to give you a heads up on how to use TBS in combination with BMD in clinical practice, mostly from the conceptual standpoint with some experience we had, and that Mike will really go over his own experience in his practice as well. So having said that, let's go with some basic knowledge that you all know, but it's always nice to put that in a context. When we talk about osteoporosis, we know it's a cystic skeletal disease characterized by low bone mass, bone density, and deterioration of bone microarchitecture. So we know from early 90s that both the density and the bone microstructure are very important, because if one of them or one of the two or the two of them just been degraded, that can lead to a fracture or to the stage of osteoporosis. As you can see here below, you see clearly a different density, but the structure is quite significantly different. So because of the early stage of the density, most of the gold standard for the diagnosis of osteoporosis has been based, a practical guideline been based on density and a T-score. So you all know the WHO definition with a T-score below, above -1, it will be normal, osteopenic below, between -1 and -2.5. And if you equal or below -2.5, you'll be considered as osteoporotic. Now, when we look at the reality of the things, we have about 50% of the osteopenic fracture that will occur in the normal or osteopenic zone, meaning that we're missing a lot of them. Well, it's kind of a normal because, as we said from the WHO clinical definition, density is not enough. We need also the structure. And here you can see on that slide that you can have exactly the same density, but the underlying structure can be quite different. So measuring the structure of the bone is very important as well in combination with the density to have a better understanding of what's happening at the bone level. So the TBS is a software that can be plugged onto the DXA system, and they will reanalyze the DXA image from the spine, and within a few seconds will provide a texture analysis which is highly correlated to the bone microarchitecture. So the bottom line is within a few seconds, you can differentiate for someone with the same density, you can differentiate two underlying structure. As you can see on that image, for example, you can have a good image, a good density or bad density, but the structure will be quite different. If you have a good structure, the TBS will have a high value. If you have a degraded structure, the TBS will be low, even though the density can be the same. So saying that is interesting, but what about the clinical studies? So as we know now, there is an extensive clinical validations, and it's been clear that from many guidelines that the TBS is a new predictor of fracture, which is independent of the BMD, independent of the clinical risk factors, and independent of FRAX. So that's very important because it's just like giving the same level of information that it doesn't add any much to the clinical routine. So usually it helps fine-tuning the assessment of fracture risk and medical decision in both men and women, and especially in some gray zone. What I mean gray zone means it could be osteopenic patients, where we know we have the overlap between fracture and non-fracture. Could be secondary osteoporosis, where sometimes the density is very high or normal, while the structure or those patients still fracturing. And that's the case, for example, in diabetes. Then we can have that in glucocorticoid-induced osteoporosis, hyperparathyroidism, and so on. Now, interestingly, it works also pretty nicely in osteoarthritic patients, where the density tends to be over-dense because of artifact impact of the osteoarthritis on the density, but why the TBS is minimally impacted by these conditions. And then when we use with FRAX, it's mostly where you have close to the intervention threshold. Another thing which is quite interesting is that the different treatment will impact TBS differently, but I will come back on that in a second. So the bottom line is you have more than 20 national and international guidelines, and nowadays we have more than 600 publications that on TBS, and more to come because you have an average of 2 to 3 publications per week on the TBS in different applications. So let me dig a bit further in some of the fracture risk, just to give you more inside knowledge here. If I start with a fairly old study, because that was the first study that we published with Bill Leslie from Manitoba, but that's still so far the largest study with 33,000 women from the Manitoba. They've been followed for 4 years, 5 years, and now there is also some follow-up up to 10 years. And all the data here have been adjusted for FRAX clinical factors. So the bottom line here is if you look at the value and you combine the minimum T-score between spine and hip, and potentially so radius if we're having it, but here is spine and hip for the Manitoba, and have here the tertile of TBS, the highest tertile meaning a high value of TBS, which is normal, versus lowest tertile, which means a degraded structure. Interesting, if you have a low value of a normal BMD T-score and then a normal TBS, the likelihood to have an insert, the internal fracture is extremely low. At the opposite, if you have a osteoporotic patient by BMD and low TBS, the risk of fracture is extremely high. But what is very interesting, if you look at the orange bar, because if you have a patient with osteopenia, where we know there is a certain number of fracture, but a low TBS, the level of risk to have a fracture is extremely high and similar to what we have with osteoporosis. So if we try to project that to numbers, and we try here to see from the Manitoba that the 1600, the more than 1600 major fracture being dispatched between osteoporosis, osteopenia, and normal, you see here that 46% of them, so 39 plus 7, are not osteoporotic. Now, if we just fine-tune that with the category of TBS between normal, partially degraded, or degraded, we can see that the dispatch is 54% in osteoporosis, majority of them in osteoporotic and degraded, but here you still have 16% of the major fracture that occurred in osteopenia with low TBS, which means that if you combine those osteoporosis plus these 16%, you will capture 70% of the major fracture instead of 54. So you have a significant amount of added value here. Now the question is, since all the previous data was adjusted by FRAX, one of the FRAX group, meaning John Canis, Mike McCloskey and colleagues and so on, were wondering whether or not to add some value to TBS. And actually, we have exactly the same trend. If you have here the probability of fracture by FRAX combined with TBS, if you combine high probability of fracture with low TBS, the probability is even higher. And the same low probability of fracture in the normal TBS, normal band, and something in between two. So having said that, then the FRAX group decided to work together based on a meta-analysis of more than 14 cohorts and totalizing about plus 17,000 patients around the world. And then they come up with the FRAX adjustment factor for TBS adjustment, FRAX adjusted by TBS, sorry. So if I take here an example of a US patient, 65, with a weight of 65 and 170 centimeters, and the patient has glucocorticoid, for example, and a T-score of -2, the probability according to FRAX will be around 16 or N3 for hip fracture. Now, if you see underneath here, you see adjust with TBS on the FRAX website. So that means if you have a TBS value, you can press that, and that will just open another page with the FRAX adjusted for TBS. So you see that already, like that was just 350,000 patients been used already, the FRAX the calculator with the TBS. If you want to calculate it, then you will have the enter here a TBS value on the calculators, and it will recalculate the FRAX adjusted. So you can see we moved from 16 to 21, or from 3 to 4.4. And if, for example, we take some of the threshold, that means you will not.
Eu entrei 7 minutos atrasado, esqueci da aula do Didier.
So the most added value about the TBS zone is where you're around the intervention threshold for FRAX. Because if you have a FRAX close to 0, so for the fracture, and then the low TBS, the TBS will not bring you to a very high probability of fracture. It doesn't make sense. So it really makes sense where you just around the intervention threshold for given countries, and in that case, about 25% of the patient will migrate upward or downward the intervention threshold. So that's still about 1 patient out of 4. So now we talk a lot about FRAX, but what about T-score? And a lot of people been using T-score, and then I took a Swiss example here, where a lot of treatment initiation have been based not on FRAX, but on T-score, depending on the molecule and so on. So because of that, with the FRAX group actually, and Bill Leslie, we decided to develop a similar approach that we use for the FRAX. Instead to the FRAX adjusted by TBS, we developed the BMD T-score adjusted by TBS by combining them together to do something that people used to have. And that, you will see how we will use that down the road. So that means if you have a T-score of minus 1.5, for example, and you have a very low TBS value, that will give you an equivalent of minus 2.5, depending how it is, if it's femoral neck, or it could be lumbar spine or total hip. So that's applied to both hip and also spine. So what about the role in patient monitoring? Well, that's very interesting actually, because when we talk about treatment, we all think about the BMD and we all think, well, pretty much all treatment made to improve patient life in terms of osteoporosis and reduce fracture risk, they all increase the BMD. And intuitively, we're just saying, well, if it's increase the BMD, other treatment will increase the TBS and the structure of the bone. Reality is quite different because the mechanism of action of the different drugs, we're not expecting that the bone microstructure will be improved as opposed to some others. So if I take here for anabolic, we'll have anabolic drugs will clearly have a major improvement of the BMD, but we also have some improvement of the bone microstructure. The same denosumab, which is something in between. Good improvement of BMD, we still have an improvement of the structure as well, because the balanced resorption formation will be favorable. Now, in terms of biphosphonate, we're not expecting to see much improvement in the structure of the bone, but we will call that the positive maintenance. The same with the Trojan, it will be a negative balance, but it should be better than just having nothing and just the impact of menopause. And actually, if you have glucocorticoid or anti-aromatase inhibitors, that will be a major impact on structure more than what we see on the BMD. So the bottom line here is that the different effect on BMD and TBS is expected, and not because you don't see any improvement on TBS on certain molecule, it doesn't mean it's work. Most of the time it means that it works, it's just differential. So here, just summarizing the impact of different molecules from different studies, and that corroborates pretty much what I said. So here you have a major improvement, both the BMD and TBS. So BMD here, much more than the TBS, the structure, which is quite normal. Then you have the denosumab, biphosphonate. MHT also have impact, just slowing down the loss compared to placebo, and the other will have major impact on the structure. So when we combine all these, the knowledge of what we had from the secondary osteoporosis and so on, and you put that in daily practice, that can give you some very heads up how to use TBS in clinical practice. So I will be a little provocative here. So this is a use of TBS in 6 steps. I will go one by one. The first one is you check the image quality. So what's happened for BMD is the same. Garbage in, garbage out. So if you have a bad DXA scans, obviously you will have a bad TBS scans. So you have to be careful that is really within the highest quality possible. And just to mention that a nice publication from ICD-IOF and survey demonstrating that still too many sites are not doing a high quality scans and should be trained appropriately. Second one, you will characterize the bone structure. So you have a reference curve. We have like a threshold of 131 and 123. If you have above or below the normal curve here, that's one thing. And then you can just characterize your patient as normal structure, partially degraded or degraded, as you do with BMD. Then the next step will be to combine the BMD T-score and the TBS so that you have a level of risk by combining whether you have an immediate risk or high risk of fracture, a very high risk of fracture, moderate risk of fracture, or intermediate or fairly normal. Now, what you have to do here when you have a patient in that zone is really ask yourself whether that's normal for age. If there is a non-secondary osteoporosis, you have undiagnosed vertebral fracture potentially, or prevalent major fracture that the patient didn't tell you, or unknown or pre-diabetic. Mostly why I say unknown or pre-diabetic, because a lot of studies now have been demonstrated that TB has been degraded in diabetic type 2 diabetic patient. Mostly it's a glycemic level and not been controlled. When it starts to be controlled, then it does go back to fairly normal values. So that's a good question to ask. Now you identify patient at a high risk, then the next question is, should I treat? And I know a lot of people get a bit nervous. For example, if you're in the osteopenic zone, to say, can I really treat my patient even though the risk is pretty high? But for that, there is two options. You will use either the FRAX approach, which means that you will use the FRAX and the FRAX adjusted by TBS, and then you will compare the risk adjusted by TBS from the FRAX with the intervention threshold of your countries. And then depending whether or not it is above the intervention threshold, you can treat, or if it's below, then you may decide not to treat. Keep in mind that irrespectively of the value, if you have a major prevalence of the FRAX, you may treat. It doesn't matter about the FRAX or the TBS, but that's clinics. So the bottom line here is really, you will compare if you have a patient with the osteopenic and low TBS, you will look at the FRAX adjusted and just improve on that is impact. But you have to be careful because FRAX will tell you who to treat, not how to treat. And that's very important because, for example, if you have here a projection of the truth, the big question is which truth? Is it the square? Is it the cycle? Is it the rectangle? It depends on the perspective. And that's very important because the same FRAX value can have a different origin. And then you can have like the same FRAX value because it's correlated. You have a lot of clinical risk factors like Moser history of hip fracture and so on, but you will not be able to reverse it. Or it could be more bone related that could be split between quality and quantity. And that the same apply with the BMD disc adjusted by TBS. So why I'm saying that is because sometimes the BMD is still important, and we'll see that in the next slide as well. So the option two to whether or not you want to treat, for example, in the osteopenic zone, is to look at the BMD value adjusted by TBS. And then that will bring potentially your patient from an osteopenic zone, like this patient here, to the osteoporotic zone as an equivalent risk because you take into account the risk associated with TBS embedded into the BMD score as we did with the FRAX. So why I say that FRAX or adjusted by TBS or BMD disc adjusted can be misleading because they will tell you you should treat, but then the question is which treatment? And this is very provocative, I know, but when we know that there is already a differential effect of different treatments, and you have a patient, for example, you are here, osteopenic, and then osteopenic patient with a degraded structure, then you know that you want to give something that will impact both the density and the structure. And then if you start to have that, then you know that biphosphonate will not be the right one. Then you will go for biphosphonate. Now, if you have here a very severe, you would like to have something more stronger. If you have here in osteopenic zone, then you can give a biphosphonate because if you maintain the structure, it's a fairly normal structure, so that's good. Or you can give MHT because even if you lose slightly, because the patient is fairly young, even if you lose a bit of structure, you still have some room before you get to a level of tumor high risk, and so on. So the concept is really to do that. The only thing which is quite interesting by using the BMD score, by the way, is that for those who do not use FRAX, can use the BMD score adjusted by TBS to enter into the Garvan index or the FRACO for Italy or for some other models. So the last slide is treat to lower risk zone, because once you have decided to treat certain patient, is how much or how long to treat. So we talk a lot about treat to target with a minus 2.5 T-score and so on. I'm not a big fan of that. I prefer to lower risk zone because again, the osteoporosis and fractures is multifactorial. It doesn't depend on one BMD value, but many other factors. So here in this context, you see that I'm not talking about osteoporotic, about osteopenia or normal. I'm talking about high, medium, low risk. Because even if you move from a high risk zone to a low risk zone, and potentially you'll be osteopenic-like, you still, and you have, for example, a prevalent fracture, the level of risk, the residual risk is still there. So here, for example, you will choose the pathway of your patient, and then you will choose the therapy, say, well, if I want to get my patient out of here, I will try to go to that line. To have that line, it will be anabolic or denosumab. If you want to say, I don't want that, I really want to give a biphosphonate, well, then you will need to treat longer to exit the very high risk of fracture. Keep in mind that the residual risk is still there. So the bottom line at the end is you don't want to treat more, you want to treat better those who really are in need. And it's very important that you always take into account the clinical context of your patients and trust your own judgment. Having said that, even if you do not see it, sometimes structure is also important. Thank you very much for your attention. Shelley, you take the lead. Mike, if you want to start sharing your screen. We can't hear you, Shelley. You're mute.
Sorry, I was trying to keep my dogs from participating in the presentation. So thank you guys. Thank you, Didier, Professor Hans, for that great information. I just want to remind everybody to please send us your questions as we're going through this. We had a couple of them during the session, some great feedback as well. And we'll now go ahead and turn it over to Professor Lewiecki, who will take us through some more clinical practical uses of TBS. And we'll leave some time at the end to have some questions and answers as well. So feel free to send them as they're going through the presentation, and we'll go ahead and take a few of them at the end. It's okay, everybody?
Yep.
All right, great. Thank you.
I guess I'm okay. I will put on mute myself now.
Okay, thank you, Shelley, so much. Didier gave you a wonderful background on TBS, and I'd like to tell you a little bit about my clinical experience. I'm going to give you a US perspective. It will be a little bit different than in other parts of the world. I'm fairly new to TBS, actually. I've been using it for about 1.5 years now. I'd like to begin with the guidelines of the National Osteoporosis Foundation, which are the most widely used guidelines in the US, and they're used in some other parts of the world as well. So with these guidelines, we recommend treatment when the T-score is -2.5 or below, when there's been a hip or vertebral fracture, and then in patients with a T-score value between -1 and -2.5, treatment is recommended if the fracture probability is sufficiently high according to FRAX. So if hip fracture risk is 3% or greater, or major osteoporotic fracture risk is 20% or greater, treatment is recommended. So getting accurate information from FRAX is extremely important, and TBS may help us to get some better values out of FRAX. Now, Didier and I have both been very involved with ISCD for many years, and the ISCD has considered TBS and made some clinical recommendations that I just wanted to list for you here. So the ISCD says that TBS is associated with vertebral hip and major osteoporotic fracture risk in postmenopausal women, with hip and major osteoporotic fracture risk in men over age 50. They recommend that it not be used alone to determine treatment recommendations, but that it can be used with FRAX and BMD to adjust the FRAX probability of fracture in postmenopausal women and older men. New with the latest ISCD official positions are some recommendations about monitoring, and that's in bold, and the next to the last bullet. So in patients receiving anti-fracture therapy, the role of TBS in monitoring is unclear, but we're learning more and more about this all the time. It's potentially useful for monitoring anabolic therapy, as Didier mentioned. It may also increase in some patients receiving treatment with denosumab, although the response with BMD is so robust with denosumab, it's not always clear from a clinical standpoint how much additional information you're getting. Sorry about the phone in the background here. TBS is also associated with major osteoporotic fracture risk in postmenopausal women with type 2 diabetes. Now, a year and a half ago, when I first started using TBS, I wanted to let our referring physicians know that we were doing TBS and what TBS was. And that's what we put into this letter on the left. We sent that along with TBS measurements that we did, and we sent it along with reports of bone density tests that we did, even without TBS, in order to educate them about TBS and explain the potential clinical uses. At the same time, when patients came in to our facility to have a DXA done, we handed them the letter that you see on the right. So as they were filling out their history form and waiting in the waiting room, we let them become educated a little bit about TBS. And then they could make a decision about whether they wanted to have this or not. In the US, for the most part, this is not covered by insurance, and different facilities are handling this differently. Some facilities, I understand, are routinely doing TBS on everybody and not charging for it at all, just including that with the DXA charge. Some are charging different rates for it, so we have a modest charge for this. Since it's not covered by insurance, the patient pays this out of pocket. So they can choose whether or not to have TBS or not have TBS. I spend a lot of my time thinking about how I talk to patients and how to explain things in terms that they understand. And when I'm talking about TBS, I usually tell them this. I say bone density by DXA essentially measures how much calcium is in your bones. And I tell them TBS measures bone structure, which is something entirely different. And I explained, as Didier did as well, that two people could have exactly the same bone density, but very different bone structure. The person with poor bone structure has weaker bones that are more likely to break. Now, they may not understand any of that very well, so then I go to my bridge building analogy, and I tell them that you could have two bridges built out of exactly the same material, but if one was poorly constructed because the construction crew was drinking a lot of alcoholic beverages when they were building the bridge, that's going to be a weaker bridge, and when an earthquake comes along, that bridge is going to fall down first. Well, that gives them a little better understanding of it. And even better than that are images, I think. These are images that are very good at illustrating the difference between poor bone structure and good bone structure. In this particular example, we have a woman with osteoporosis who had a baseline bone biopsy on the left and a follow-up bone biopsy after about 18 months of treatment with teriparatide. I have little plastic models representing exactly the same thing, and I have these models in each exam room, and I use them as examples of poor bone structure and good bone structure. And after the bridge building analogy, plus seeing the models that I show them, they then seem to have a much better understanding of what we're trying to measure with TBS. Now, here are some examples of how TBS might help with clinical decisions. And probably the most important is with FRAX adjustments when treatment decisions are borderline. Because with the TBS FRAX adjustment, you may cross the treatment threshold one way or the other, and it may influence how you're going to treat the patient. There are some patients who have lumbar spine BMD that's invalid due to degenerative change, yet it's still possible to get a valid TBS measurement. and that can be helpful as well. There are disorders where fracture risk is out of proportion to bone density, and these include type 2 diabetics, patients with primary hyperparathyroidism, patients on anti-estrogen therapy for breast cancer, chronic kidney disease patients, and those on chronic glucocorticoid therapy. Another category of patients that is especially interesting to me are those who have had orthopedic surgery and are told by their orthopedist that they have soft bones. And yet, when we do a bone density test, it's pretty good. It may be normal or only slightly low, and not enough to explain what the orthopedic surgeon is encountering. I believe the orthopedist when he says the bones are soft. The question always comes up whether there's a systemic skeletal disease that needs to be addressed, or whether this is a local bone problem in the area of surgery. And TBS may provide some enlightening information in that regard. Sometimes we see patients with low trauma fractures, even though bone density is normal or only slightly low. TBS may provide helpful information in that case. And in any situation where there's uncertainty about fracture risk and treatment, TBS may be helpful. So Didier showed you the FRAX algorithm on the web page, which you see here again on the left. I like FRAX. I use it every day in my practice, and I appreciate the benefits. It provides a quantitative measurement of fracture risk. There are robust supporting data. It's incorporated into DXA software, and it's in smartphone apps, and it's part of many clinical practice guidelines worldwide. However, it has limitations as well, and anyone using FRAX must recognize this. It's missing some risk factors. For instance, falls is not included in FRAX right now. And certainly it's up until TBS was added to it, there is no way to account for bone structure. It has dichotomous input for risk factors that actually represent a range of risk. There's a variable range of error in the output that you get. Only femoral neck BMD is an input. And in the US, we can only use 4 ethnicities. That's Caucasian, Black, Asian, and Hispanic. There's always been a little bit of a question about how we handle Native Americans, and it's recommended by the ISCD and the IOF that Native Americans be entered as Caucasians in the FRAX algorithm. Now, here are a variety of FRAX adjustments that can be made. So it's not just for TBS, but for type 2 diabetes, you can check off rheumatoid arthritis, and it's a pretty good surrogate for the increased fracture risk associated with diabetes. You could reduce the femoral neck T-score by minus 0.5 or use input from TBS. When there's discordance with the hip and spine BMD, which is a clinical concern in occasional patients who have very low spine BMD and hip BMD that's not so bad, we're probably getting an underestimation of fracture risk when we do FRAX. You can make an adjustment for that. For high-dose glucocorticoid patients, you can increase the risk of major osteoporotic fracture by 15% and hip fracture by 20%. And of course, TBS can be used with the FRAX algorithm now. Interesting data has come out of Manitoba that if a parent has had a hip fracture over the age of 80, that has very little relevance in terms of the fracture risk of the offspring. So at least in the Manitoba population, you could use this as a rationale for asking the patient the age of the parent when they had a hip fracture, and if they were very old, they could consider not including that in the fracture risk algorithm. So here's an example of TBS adjusting the FRAX value upwards. This is a 65-year-old Caucasian woman with osteopenia, no clinical risk factors. The femoral neck T-score is minus 2.3. And FRAX is below the treatment threshold. So major osteoporotic fracture risk 11%, hip fracture risk 2.1%. So according to the NOF guidelines, this patient would probably not be treated. However, where you see the oval here is the adjustment for TBS, and that's shown on the right-hand panel. TBS in this particular situation was low in the degraded range at 1.118. The adjusted FRAX values were 14% for major osteoporotic fracture and 3.2% for hip fracture. So with the NOF guidelines, this patient now meets the treatment guidelines, and you don't have to follow the guidelines, of course, but you might be more likely to treat this patient than you would have before you had the information from TBS. Here's an example of TBS adjusting the FRAX value downwards. We have a 55-year-old Caucasian woman with osteoporosis and no clinical risk factors. She's got a pretty low T-score of minus 3.0. FRAX is above the treatment threshold, as you do here. But what if you did the TBS adjustment? In this case, the TBS was in the normal range at 1.367. And certainly, as Didier showed you, it is possible to have osteoporosis and have normal TBS. In this case, the adjusted FRAX values ended up being below the treatment threshold, so at 9.6% and 2.1%. Now, you may decide to go ahead and treat this patient anyway because the treatment is recommended for this T-score value. But in terms of having a conversation with the patient, letting the patient know that fracture risk is not terribly high, and that's a rationale for consideration of withholding treatment. And sometimes I have patients who are very reluctant to be treated, even when fracture risk is very high. And this provides a rationale for the patient's level of comfort if they choose not to be treated. Certainly, if you chose not to treat this patient, you want to monitor them carefully. And I would have this patient come back in a year, in any case, for a follow-up bone density and reassessment of fracture risk. Now here on the left-hand panel, you see a typical TBS report. This is from our facility on a patient I saw this week. So that's what it looks like. Here in the oval is the TBS value. So I look at that and I classify the patient as being normal, partially degraded, or degraded. So this patient happens to be degraded. There's a graph below with a little white box that represents the patient's TBS. The patients like looking at that graph, and I tell them where you want to be is up in the nice green area at the top part of the graph. And if you're below that, your bone structure is starting to be degraded. We look at the image in the right upper part of the panel to be sure that this is a good quality image, that bone edges are put on correctly. And the second oval here gives the adjusted FRAX value. So these are the numbers that I take off of the report, and I include it in my final DXA report. And on the lower left part, you see values for individual vertebral levels and different ranges of vertebral bodies. Sometimes that can tell you if there's discordance in TBS values at certain vertebral levels, and that might possibly lead you to analyze this in a somewhat different way. So this is the printout from the current software I use. On the right is software that I do not have, but this is the new version of software that's coming out, and it's organized a little bit differently. Didier showed you some of these portions individually, but here where I have the latest oval gives the TBS value, And it also gives you the diagnostic classification, so you don't have to look at the number and decide what the classification is. In this case, it's automatically printed out. Down below in section 4 of this, you get adjusted FRAX for TBS, and these are the critical numbers that you use. You get an adjusted T-score, which I'd probably be personally less likely to use than the adjusted FRAX value. And if you like the idea of that panel in the lower left-hand corner, you can categorize the patient according to what the T-score shows and what the level of fracture risk is. And that may be helpful in helping you to think about it, and it may be worthwhile to show that to the patient to help them understand better what their level of fracture risk is. Now, this is a second page of the new version of the TBS software. What this does is give you more detailed information, including the values at individual vertebral levels, and it gives you a conclusion, which I've blown up here. So, as I understand it, this is automatically populated by the data derived on the first side of the page. And this gives you a nice report, and you could make a copy of this to go to the referring physician or give it to the patient so they have a better understanding of what their bone quality and fracture risk is. Now, Didier mentioned a little bit about monitoring. I just wanted to point out that as with DXA, if you want to monitor with TBS, you must do precision assessment in order to get a quantitative assessment of any changes and distinguish what's a measurement error from a statistically significant change. So if you're going to monitor, you do precision assessment precisely the same way as you do with DXA. You calculate your precision error, you multiply it by 2.77 to calculate the least significant change with a 95% level of confidence. We've done that at our facility, and what we found and what's been found at investigative sites who have looked into this is that the precision of TBS at the lumbar spine roughly tracks with the precision of bone density measurement at the lumbar spine, but generally not quite as good. At our facility, when we did it, our least significant change for TBS was 0.060. Our least significant change for BMD at the lumbar spine is 0.030. So definitely higher for TBS. And we may want to repeat that and see if we can do better with our precision error as we go on. Monitoring TBS may provide clinically useful information in some situations, in addition to the information that we get with bone mineral density and bone turnover markers. And my personal opinion is that it might be especially useful in patients on anabolic therapy, such as teriparatide, abaloparatide, or romosozumab, who may not get the kind of robust increase in bone density that is commonly seen in clinical trials. And often patients in clinical practice, who as you know are more complicated than clinical practice patients, may have a disappointing bone density response. And it would be quite encouraging for you and also for the patient if you could look at TBS and find that there is an improvement in TBS that may go beyond what we see with the change in bone density. Now, there may be a significant TBS decrease in a patient who's not on treatment, and this is certainly consistent with increasing fracture risk and cause for clinical concern. If it decreases in a treated patient, this suggests to me a suboptimal response to treatment, and I would certainly consider evaluation for poor compliance and other unrecognized conditions that might be contributing to this. If there's a significant TBS increase in a patient not on treatment, I would say in general that's unlikely to occur, but it could be due to some non-pharmacological intervention that's having an effect. In a treated patient, it's consistent with a favorable response, especially with anabolic therapy. It may be observed in some patients on denosumab, and we've seen that happen in some of our denosumab patients. But in general, these patients also have a very nice improvement in bone density. So we know in any case that they're responding well to treatment. It would not be expected with bisphosphonates because the changes in TBS are small, especially in comparison with changes with BMD. So to summarize, from my view on TBS, we have robust data supporting TBS adjustment of FRAX. It can be a tiebreaker for borderline clinical decisions. I think it's helpful in terms of patient education. As I mentioned, we have many patients who are reluctant to be treated, sometimes even when fracture risk is high. And if I can demonstrate to them that their bone structure is poor, that may persuade them to get on to treatment in a situation where I believe the benefits far outweigh the risks. It may be useful in monitoring some patients, and it is FDA cleared as a complement to DXA. Limitations are the software must be purchased. You cannot use this to diagnose osteoporosis. It's really one of many data points that we need to consider in making clinical decisions. We must do precision assessment and calculate LSC if we're going to use it to monitor. And in the US, at least at this time, it's not covered by insurance. Now, I wanted to transition just a little bit with a couple of slides to tell you something about bone health tele-echo. If you like the idea of online education, and I assume you must like it at least a little bit if you're listening to me right now, you might be interested in bone health tele-echo, which spends a lot of time talking about the evaluation and treatment of patients with osteoporosis. And TBS is actually part of the regular conversation with bone health tele-echo. There's a website there below for anybody who wants more information about this. You can register for it and find out more what it's like. So once a week, at least before COVID, I went to a university teleconferencing center. I sat right where you see that view. I look at a small computer monitor directly in front of me and some large screens on the front. I think this happens to be a parathyroid talk that John Bilezikian is giving. What we typically do at these sessions is have a very short presentation on a topic of interest and then present cases to one another. And these are real cases, and we discuss the cases. So this is called technology-enabled collaborative learning. It constitutes a virtual community of practice for sharing knowledge about osteoporosis. It serves as a force multiplier. So this goes far beyond telemedicine, where one doctor is taking care of one patient located remotely. What we're doing here is educating healthcare providers to each take care of many patients and do better at managing osteoporosis. And the goal, of course, as with everything with osteoporosis, is to prevent fractures and reduce the treatment gap. Interest in this has been rising, and it's going up even higher this year. This was started in 2015. It was held once a week, and we averaged 13 participants each time we had a session in 2015. Last year, it averaged 52 people per session, and I haven't seen the numbers for this year, but I'm sure it's quite a bit higher. Just to give you an idea of the reach of bone health tele-echo, this is called a hub and spoke system. The hub in this particular case is in Albuquerque. We reach out to healthcare professionals across the US, and we have had participants in many other countries as well, as you see on the panel on the right. There are other bone health tele-echo programs that had started up in other parts of the US and in other countries and in other languages, and I suspect there are many more to come. There's also a rare bone disease tele-echo that meets once a month, that's an opportunity to learn more about rare bone diseases and to manage your patients better when you happen to have these patients. So I'm going to take my screen off, and I think we can open this up to comments and questions. So thank you for your attention. Shelley, you need to unmute.
Thank you. I have two different mutes here, speaker and the computer. Thank you all, and thank you for that information. It was very, very helpful and informative. We've had several questions come through during the presentations, some of which they were answered as we were going through, and thank you. I think Professor Hans did some, and I did a couple of them as well. But why don't we go ahead and take a few of the ones that we have here. We won't be able to get through all of them. If you guys have some specific ones that you're not hearing, please let us know. If we can't get to them today, we will get to them next week and be able to provide answers to all of them along with a link to this recorded session as well. This is a good question. This is from Hung Dam. It is to either one of you guys. If you remove a lumbar spine level from a BMD due to arthritis, should the level be or not be included in the TBS analysis? I think that's a common question, so I thought I would take that one to present.
Okay, I can start if you want, Mike. That's an easy one. So by definition, if we apply ICD rules, then we should exclude vertebrae that have more than one standard deviation different compared to adjacent vertebrae. So the fact that TBS software will capture the region of interest that was saved in a BMD, so what you exclude will be automatically excluded in a TBS. Now, knowing that the TBS is minimally impacted by osteophyte, potentially if excluding from a BMD will exclude too many vertebrae, you can still use it as a full number for TBS. And unlike BMD, BMD, you cannot make an arithmetic mean of L1 plus L2 and 3, for example, but with a TBS, you can do that very easily. So you should have different combination, and you can use that if you want. Now, if you have a vertebral fracture, then I would strictly recommend that you exclude the vertebrae on both sides, even though it would be minimally impacted for the TBS, depending on the type of fracture.
Yeah, let me follow up on that. One of the interesting things about TBS is that it does not seem to be affected very much by degenerative changes in the posterior elements of the spine. And it took me a while to understand this. Didier was very patient in trying to explain to me that the TBS is still valid, even in cases where the spine is not very useful at all for measuring bone density because of degenerative changes. It may be possible to still get valid TBS measurements. And essentially, what we're looking for is heterogeneity of the trabecular structure in the vertebral body. We're looking at holes in the bones at the microscopic level. And it can still do that pretty well, even when there's confounding calcium deposits in the posterior elements of the spine. So I was actually surprised to see this. It took me a lot of convincing to believe it was really true. And I think probably it's mostly true. There may be some cases where, depending on the type of degenerative arthritis, it may be a confounding factor. But in general, I think TBS is still valid.
Yeah, actually, there is also a lot of study in rheumatology with ankylosing spondylitis of bone spine, and that was still not impacted that much. But agreed, if it starts to really be too much is too much. So we have, that's why I say minimally impacted, not impacted. And then at the end, it's just like a matter of medical decision. Great.
Okay.
Maybe one of the question here I see from Larry that I've been asking for quite a while about the lateral DXA. So that's an easy one to answer. Hi, Larry, first. The thing is, the idea of the TBS was just to sneak into the workflow and not changing the daily routine. So as you know, the lateral spine had been used in clinical routine by many people. Now, having said that, one thing you have to keep in mind is that the TBS have been developed based on a CT scan first, meaning without the posterior arch, and that was still demonstrating a very high correlation with bone microarchitecture without the posterior arch. We did some study with it, without, and the posterior arch was accounting for about 20% of the total amount. Now, lately, we've been presenting some TBS value from research with Neil Binkley, where we're currently writing the article, where we've been measuring the TBS laterally. And obviously, the lateral also works. That was also published by Christian Roux from Paris on X-rays. So it worked pretty nicely, sometimes even better than AP spine. But again, most of the people don't use the lateral spine, so that's why we have to do both. But with the Neil, that's why we've been using not the lateral spine, but the VFA scan in order just to get some assumption. But that's pure research, and that's not yet for clinical routine.
Okay, great.
Yeah, let me go on to another one of the questions. For the benefit of the clinical community, could you elaborate on how TBS 3.1 is different from previous versions? Well, I've not used the latest version, but and Didier can tell me if I'm wrong, but the TBS measurement is the same as I understand it, but the printout is different. One difference is it gives you a diagnostic classification where in the previous version, you have to figure that out yourself. It gives you a nice little table putting the patient into a category in terms of fracture risk. That may help you in making clinical decisions, and it may be an educational tool for the patient. It gives you a FRAX adjusted T-score, which we don't currently have in the older version of the software. And it gives you an automated report. I understand that report can be modified by the tech if necessary, but you don't have to come up with a report on your own each time. If you want to use the automated report, it's there, and that may provide some useful information for your referring physician in a standardized format. Didier, did I miss very much?
I think, no, you've been great. Don't say too much, otherwise Shelley may hire you just to make the promotion. I'm kidding. Actually, yeah, that was the bottom line. What we noticed is a lot of people, there is now more than 2,500 TBS worldwide. And a lot of people say we were a bit confused how to use it in clinical practice and what to report in the software and so on. So that's why, based on experience we had at the clinic, we just pushed Medimaps just to include in a total report, a fully automatic report, especially for radiologists, to normalize the outcome and also for WHO criteria. So we're just giving a full automatic conclusion within a few seconds that you can edit if you don't like it, or you can use as it is just to normalize a bit what has been done. So that that's the main difference. The FRAX adjusted, the BMD T-score adjusted by TBS, and the automatic conclusion and the categories, as I mentioned, just to easy interpretation, as you said.
Great, great, thank you. I know that we've had quite a few other questions kind of come onto the screen just recently.
Oh, 21, yeah.
Yeah, so obviously we won't get through all of those, but I wanted to have an opportunity for you guys to pick a couple of them that you might think would be helpful. I did see one here that was of interest that I thought would be good given the fact that we're talking about it, TBS in clinical use. And Didier, I know you went over some examples of looking at BMD and TBS and trying to decide what's appropriate for treatments. One of the questions was, is it possible to have deteriorated TBS before BMD, therefore which would be the treatment? Anabolics with the question, specifically in secondary osteoporosis with endocrine therapy. And I know since, Professor Lewiecki, since you see this in routine, and I know that there was a discussion about how to use the combination of TBS and BMD together in clinical routine, I thought this was a good question to pose to you too.
Well, I can start if you want. That's a kind of a clinical question. In theory, if fracture risk is very high and TBS is very low, both of those issues might lead you to use anabolic therapy. You're most likely with anabolic therapy to have improvement in bone structure. And if you know in advance that it's degraded that's an obvious choice. I'd like to point out that there are some emerging changes in clinical practice guidelines as far as risk stratification and selection of initial treatment. And this has been the case with the new ACE guidelines that came out just a few weeks ago. And I think you're probably going to see it in the new NOF guidelines that I hope will be coming out in the near future in the next couple of months. And that is that if fracture risk is low, we generally think of not treating. If fracture risk is high, we treat with something. Often that's a bisphosphonate because that's the least expensive drug and it's widely available. And if fracture risk is very high, in that situation, we consider anabolic therapy or perhaps denosumab. And the question comes up, how do you define very high fracture risk? And ways that I would define that as very low T-score, such as T-score less than -3 or less than -3.5. If there's been a recent major osteoporotic fracture, such as a hip fracture, humerus fracture, vertebral fracture within the last year. And I would add on to that, if TBS is degraded, that would be another factor that might put the patient into that very high fracture risk category and lead you to think more about anabolic therapy. So, Didier?
No, I think that's a good answer. And the thing is that's why we came out with a FRAX. If you have like a fairly normal BMD or osteopenic and you have a low TBS, then you just don't treat like this. For us, we've just been using either the FRAX adjusted or the BMD score adjusted. So if it's below, then become below -2.5, then we can start to initiate treatment, or above the intervention threshold from FRAX. But then that will depend very much about the clinical context as well. So I'm pretty much aligned with what